So most of you know that years ago, those of you who are from St. Louis or close to my age, when I was growing up, my grandma always talked about Arsenal Street as if it was a bad thing. They'd say, oh, if you act like that, you're going to end up on Arsenal Street. I didn't know what it was. But it was the State Psychiatric Hospital, which at one time had 5,000 people in it, and now there's about 200. But that was, you know, for the better part, the first half of the last century, that was pretty much how we cared for people with serious mental illness, was institutional, long-term institutional care. In the 50s and the 60s, a number of major sea changes happened. One was the development of the psychotropic medications, which made it possible to treat people, to think about treating people outside of the facility. The medicines helped with the worst of their psychotic symptoms, with anxiety, with agitation, and they were nowhere near as sophisticated or as titrated properly as what we have now, but it was a major step forward. Another thing that happened was Medicare. Medicare made it possible for funding from the federal government to pay for care in the community, and that's key. That's key. Another thing that happened at that time was in the 60s. We became aware that all kinds of people have rights who in the past we didn't think had rights. There were a number of court cases that said you can't institutionalize people against their will unless they're a danger to themselves or others. So all of these things kind of coming together in the 50s and 60s led to what they call the deinstitutionalization movement. Now, deinstitutionalization is supposed to be moving away from institutions. In many cases, what it meant was moving from one institution to another. And that's when I came into the system in '72, and I worked at the state hospital, and I had a position in what was called the community placement program. And I had a caseload of about 1,000 people. Imagine what wonderful care we provided. In some states, there wasn't even a system like that, but people were just discharged en masse with no follow-up. My job was to see people once every 6 months and to visit every facility once every 30 days. I hated it. I came back to the office and cried. It was not a way for people to live. People who had been discharged from institutions, they were moved to St. Louis from Fulton, from Farmington, moved to St. Louis for placement out. They had their belongings in a little bag, sent them to a nursing home or a board and care home. Some of you may remember there were some old SRO kind of hotels. There was the Hamilton, the Fairground, parks that were all then bought up and turned into nursing homes to take this big influx of state hospital patients. So anyway, that was the genesis of places for people. Thousands of people being placed inappropriately in other institutions. Visionary psychiatrist Hilary Sandel said we could do better. She went out, rented an apartment with her own money, under her own name, took some people from the ward over there for lunch and said, how would you like to live here? That's how we got started. Very grassroots. No grants, no paperwork, no guidelines, you know, all that stuff now that you can't move out. And so it was sort of just an underground movement. We took furniture from the old state hospital at night, liberated it, but as they would close the wards and people would be moved out, we used the state hospital truck, took these hideous metal chest of drawers and bed frames and set them up in apartments because we had no money. Gradually, the state saw this might be not a bad idea, and it was cheaper than some of the other things they were doing, so they gave us $80 for startup money. And in those days, you could still find an apartment in St. Louis, I know, because I lived in some of them, for like $60 a month. You know, the little flats with the shotgun flats, and sometimes they had the big old ugly space heaters in the middle of them, but that's how we started, with no money. So what happened was, as more people were being placed out of the hospital and in institutions nationally, there was an idea called something called a continuum of care. And the notion was that, okay, not everybody needs the same thing. So what we need is a continuum of different places where people can live. And so maybe people who need the most restrictive care, you know, are in the hospital, and then the people with the most independence and the least need for support or supervision can live on their own. And in between, there would be all these other stops along the way, like halfway houses, they called them, and group homes, and just all kinds of things. So in the 70s and the 80s, all around the nation, states began to implement what they called a continuum of care model. And they started looking at people they were discharging from the hospital and saying, well, let's see, what level do they fit in? A group home, a boarding home, a semi-independent apartment. And so we started building around the country these various, with A11 money, with a variety of HUD money, HUD 202 money, started building a variety of these facilities for people to live in. And by the way, I should have mentioned what maybe is obvious, that what drove deinstitutionalization wasn't so much the court cases, it wasn't just the medication, it was money. It was cost shifting. It was cost shifting from the state, from the state to the federal government to the communities, and that's not usually the best driver for social justice movements or healthcare, is cost shifting. And so what happened was it was seen as a way to save money on these state inpatient facilities, but they didn't then take those savings and build a community support system, and that's what we've been trying to make up for the past 30 years. So anyway, so they started building these different levels of care for people to live in. And some people thought, well, that's a good idea because then there's more options for people. But the problem was that these different boxes along the way, the continuum of care model, were implemented kind of rigidly. People were assessed and they said, well, you know, you have X number of deficits, so you need to go into this box. And guess what? A lot of people didn't like the boxes they were put in. And so some people said no. And when they said no, they said, we don't have a place for you in our system. And so we started to see the growing number of people with mental illness that were homeless. In addition to that, in the 80s, for better or for worse, Ronald Reagan's administration cut back on support to housing in HUD. And we saw a decrease in affordable housing. At the same time, our cities were seeing a deterioration of housing stock. So combined with a lack of affordable housing and a lack of a good community support system with easy access to mental health care, we saw this huge, huge increase in the number of homeless mentally ill. And for me, it was tangible. Our building on Places for People is on Wendell, and we're on a main drag. So it was a tangible increase in the number of people. And at first, it took me by surprise when people would knock on the door and it was clear that they were psychotic and they were homeless. I was, in the beginning in the 80s, not accustomed to that. Now I expect every morning when I come into work to see people that I've never seen before who are sick and who are homeless. Some still in a hospital gown and a bracelet, a hospital bracelet on their wrist. Now that's a disgrace. Said I'm not the boss anymore, I'm speaking for myself. So one of the things that we've tried to do at Places for People, and we're trying, and frankly, the Department of Mental Health has been trying to do, and working with the provider system, but it's very hard when each year your funding gets cut. It's very hard when you put in place a 5-year plan or a 10-year plan, and then boom, the money you had to implement that plan every year gets decreased. So that's been a challenge. But one of the things that we've been trying to do is look at the connections between housing and mental health issues. And one thing that we know, and it's been shown in every study that's been done all around the country, is that some of the highest users of emergency room services with a mental illness are people who are also homeless or living in inappropriate housing where there's abuse, housing where they're just being able to stay because they got nowhere else to go, but it's not a good situation, in boarding homes or nursing homes where they don't want to be, and so they act out, and so 911 is called and they're taken to the emergency room. Housing is key to helping people with serious mental illness recover their lives. And I think we're finally starting to recognize that, but now doing something about it is another matter. What we've done in Places for People is not throw the baby out with the bathwater. As the country began, again, the field in the 90s started to look at this continuum of care we had built with these boxes where people were supposed to go, and started to say, you know, I wouldn't want to live. I don't know how many of you ever lived in a commune. I did a couple times when I was younger. It didn't work for me. So just because you have a mental illness doesn't mean you want to live in a congregate setting, right? So people were being put in rooms and houses and places with people they didn't particularly want to live with. Sometimes people with the most extreme or vulnerable of their psychotic disorders did not want to live close to other people. It made them more paranoid. They acted out more. They didn't feel good. And they wanted what you want, what I want, my own place, a key to be able to come and go when they want, pick what they want to eat.